Thank you so much for investing your time with us this Friday afternoon. Welcome to our live webinar today, Humility and Humanity, Bridging Public Safety and Public Health, co-hosted by Operation to Save Lives and Lilywop. Our focus purpose here today in our opening is introducing why bridging public safety and public health is so critically important. Our objective with our time today is to discuss our nation's current social issues, substance use and mental health disorders, as well as racial inequities. Now more than ever, the integration of public health and public safety is critical to effectively addressing these public health crises. Through today's discussion, our hope is to promote community collaboration by bringing together stakeholders across multiple sectors to address these crises, which have been further exacerbated by COVID-19. Our panel consists of expert leaders from law enforcement and public health collaborative initiatives. Today, we are joined by Chief Operating Officer Scott Allen, who through Community Services Solutions has created Operation to Save Lives. Scott Allen is a retired police chief of East Bridgewater, Massachusetts Police Department. He was a leader in developing a county-wide integrated behavioral heal model, Plymouth County Outreach. Through Operation to Save Lives, Scott and his team provide training, mentoring, and program services for new or existing multi-sector collaborations across the country. We also have the privilege of being joined by Director of Public Health, Dr. Nathaniel Horwitz-Willis. Dr. Nate is an assistant professor of public health at the Massachusetts College of Pharmacy and Health. He is the founding principal of Lilywop, which focuses on improving the conditions in which we learn, live, work, and play within communities across the globe. He is also a leader of the MA COVID contact tracing. Retired Police Chief Frederick Ryan comes from Arlington, Massachusetts Police Department, where he was chief for 20 years. In 2008, through Chief Ryan's leadership, his agency embedded a mental health clinician within the department who co-responded to assist vulnerable populations. Further, he has been a national leader of the Police Assisted Addiction and Recovery Initiative, serving as board member and law enforcement council member. Dr. Jamil B. Scott joins the discussion as a community engaged public health researcher, educator, and administrator. Her work is focused on chronic disease prevention in communities of color. In recent years, she has also taught skills around mitigating unconscious bias and trauma and increasing resilience to both community and academic audiences. We are also joined by Craig Smith, who is a seasoned law enforcement and mental health officer hailing from one of the largest metropolitan police departments across the country. Craig Smith currently serves as sergeant, who has been responsible for engaging with and assisting vulnerable populations. Finally, before we begin our discussion, if those attending today's webinar would like to submit questions to our panelists, please utilize the Q&A function at the bottom of your screen. Thank you for joining us today. Craig, can you share your experience engaging in public health and public safety collaborations coming from a major metropolitan police department?
Thank you, Rachel. So as a law enforcement officer of nearly 14 years, one of my critical jobs is interacting with the mental health community. And for me, that's very important because we know they're one of the most at-risk communities in our nation. So for me, it was about working with the public health side of things, is also getting sure that the mental health people get treated for the root causes of their problems, so that we can actually get and so we can make sure that the problem gets solved, so that it's not this continuous call, 911 calls for the same thing over and over. So it's just getting them the help that they need.
Thank you. Fred, can you tell us how you've engaged in public health and public safety collaborations in a mid-sized city?
Yes, thank you. And thank you for the introduction. Welcome, everybody. You know, it really, for us, it was around our goals to become more data-driven around all of the services that we provide. And when we began to work with our crime analysts and really drill down on what was driving our calls for service and what was compromising the quality of life in our jurisdiction, it became abundantly clear that calls for service based on behavioral health and addiction, as formally documented, was at least 11% of our calls for service. And we know that that set the floor rather than the ceiling, and that, you know, overdose deaths and non-fatal overdoses combined with co-occurring disorders was the biggest issue driving calls for service and compromising quality of life again. So we went to our public health partners and said, we need your help. And from that was born our co-responder program.
Thank you for that. Scott, how have you engaged in public health and safety collaborations in a smaller suburban town?
So and thank you, Rachel, for moderating today's panel and for your introduction. You're a junior at George Washington University, so we want to make sure we get that shout out for you, and thank you for all your work in facilitating this. Yeah, as a smaller suburban town, I think the neat thing is here we have Craig from a major metropolitan police department. You've got Fred's experience from a mid-sized city, right along the city of Boston, and then myself. I was an officer, the chief of police in a town of 15,000 residents. But the consistent thing between all three of our agencies is that call volume. As Fred said, from my call volume, the top calls were mental health disorder related, substance use disorder related, with those co-occurring disorders, domestic violence related, which oftentimes had underlying, social determinant health causes that were determined to be either mental health and or substance use related. So it really, as law enforcement and as police officers, we had to do something to change the way we were handling those, because quite honestly, our training on our tool belts as law enforcement, when I went to the police academy in 1995, was for mental health, substance use disorder. The only thing we really could do was push them to the courts. We really didn't have any tools in our tool belt. So it really changed the way we think. And for me, it was around 2012, I got involved with a local substance use coalition called EB Hope. And then shortly thereafter, I learned about PARI, the Police Assisted Addiction Recovery Initiative. I reached out to Fred's team, to Allie Hunter, who we have on this on our call today, the executive director at PARI, and really started to talk with these different departments and say, hey, I see that you're doing something different to address these issues. What are they? And the number one thing that came back was, we're engaging with the experts, the public health experts that we are not, but we're partnering with them so that they can help mentor us on how to respond to these. And from that, was born our initiative in our county, and it really has evolved to this integrative behavioral health model.
Dr. Nate, how can or should public health and police partner?
So yeah, I want to echo and say thank you for hosting this and having us on, and I also want to give a shout out to my new home, that's Dorchester, aka the Dot in Boston, Massachusetts. So big shout out to my peoples if you're watching this, and then Chief Gross, big shout out. So now let me get to that. When we're talking about collaboration, it's really sitting down together, sitting on Zoom and it's just talking, similar to this. You don't see it happen that often to where you're having the police taking the lead and public health taking the lead and saying, wait a minute, we can co-lead, and you have to set that table that way. And in my experiences in doing that were when I was, the director of public health in the town of Plymouth, in which we're actually, leading the nation in this model, and where I actually got to work with, Chief Allen, when he was doing his innovative work, and also with Chief Michael Boteri as well, very instrumental players in that space, in which they actually brought me on as a public health advisor, and doing small things such as articulating the data in such a nuanced way so that way they can see it from a different perspective, help to play out things a lot more better. Specifically, when we talk about sensitive topics in our nation, around race, being able to talk about, well, who's most impacted, and not just talking about a narrative that people are so used to hearing, So a good example of that is one of the key narratives that we saw was that, young white men who were socioeconomically depressed were at a higher risk for substance abuse disorder, and we also saw higher risk amongst individuals who are people of color who are of immigrant status. So how do you cut those corners, and we did that with data. But we sat down, we talked through it, and it was like, wow, we didn't think about it this way, and how do we approach it? So you got to start out that way, and it's really simple. Sit down, everybody's involved in the public health and public safety space and addressing a lot of these problems. So that's probably my first key insight, and I know we'll get into some other stuff later, but I want to say that's how you establish that equitable base, by doing that.
Thank you for that. Dr. Scott, we talk about the health of populations, but what about the risk of officer burnout resilience? In your view, how should we monitor the health of public safety officers, police officers, in terms of burnout?
Okay, so this is my first time to comment. Again, I'll thank the organizers for inviting me to join into this conversation. I would like to take a small step back and talk about partnerships again, because I think it's in valuing and understanding partnerships that we can begin to see each other and be concerned for how the work impacts us as individuals and how the work impacts the community. So I think it's important to enter the space with a shared respect that although we each represent our own areas of expertise, the solutions that we're going to find are shared and integrate all these multiple different perspectives. So once we get to that understanding, I think we develop a foundation of concern for each other, because the work is difficult. It's difficult for any one perspective, and even though we create strategic partnerships, it's still hard work. Serving the community and protecting the community is difficult work, no matter how you slice it. So it's important for us to find those strategic partnerships that allow us to share that burden. And so then we can move on to trying to understand trauma and resiliency and what it looks like to do this work in the face of what the data indicates and what the realities are. I think it's important to integrate training that helps us to name what we're feeling, and that it's okay to name what we're feeling. If I'm tired, if I'm burned out, now is it I just didn't get enough sleep last night tired? Or is it we've been up against these challenges for the past 5 years and the needle isn't moving as fast as we would like to, or that we thought it would move, and that we need to now take a step back, maybe shake up the conversation and come up with new solutions, because no one wants to do the same thing over and not be able to see change and not be able to see results. So it's all about, for me, having inclusive conversation, but also being willing to tell the truth using data, but also, as Dr. Nate said, being nuanced about what that data means, bringing an element of respect to all conversations, because we all have our own life experiences, our own professional experiences that we're bringing into this shared space, and we are not going to agree. So again, with the trauma and the resilience and the stress, it's about also learning how to have these conversations and disagree in a way that's constructive and in a way that moves the work forward, because the ultimate goal is to ensure safe communities. But in so doing, we also want to ensure the safety of public workers, times going into dangerous spaces to make decisions about, in a split second, what kind of help a person needs next. So that's what I think about the trauma and the resiliency, but also how to partner in community.
Yeah, Dr. Scott, I'm glad you brought that up, because really, you know, that's the key piece, is those partnerships lead to relationships that lead to true collaboration. Because what I learned early on is I didn't know a heck of a lot about substance use disorders. I didn't know early on that it was a disease. I learned that from collaborating through my local substance use coalition, from talking to clinicians, from learning from doctors. You know, I had the opportunity to engage with a lot of different medical professionals through my advocacy with EV Hope and then Plymouth County Outreach and PARI. But I love how you said that shared respect. We both have these different professions in our sectors, but we can work together to break down those silos. So I mean, I think you hit the nail on the head, and that was more of just a comment to say thank you.
I was wondering if the rest of the panelists would like to jump in on that question. How can or should public health and public safety partner?
I want to say I can appreciate both of our colleagues' comments, and that's not fluff talk. That's real talk, right? And a lot of it is understanding the history of public health and also public safety, meaning EMS, fire, policing, and then talking about law enforcement, right? Understanding those histories help to understand how do we go about shifting or changing the paradigm to get to the best results for safety and also for health outcomes for the public at large, right? So, for example, what I'm saying is that we know that, and it doesn't matter what nation you're talking about, any nation in the history of humanity has had some underpinnings of starting out, but we've always evolved. The key thing is going back to what Dr. Scott said, is like, you got to realize, like, how is the work being done? And you got to be honest about it so you can move and progress. It's not a think. I know that agencies are struggling to be honest about how they are conducting and doing business. I know that when agencies say, wait a minute, are we really utilizing this in the best way? And then they say, well, what does the data tell us? What are some of the best practices? And then what is the outcome? When you do those three things, you're going to go leap years beyond what you could ever imagine in terms of getting to an actionable and realistic result that's going to benefit a system like a society from an economic perspective, health perspective, safety perspective, and just overall well-being. So I think we have to acknowledge what was done in the past in order to understand the present to get to a better future. So that's what I really want to hamper on right there in that, in my comments of what was said.
And I think that's excellent, because here where I work, the police officers actually have more power than a lot of doctors, specifically ER doctors. So if I take a mental health call of a suicidal subject, once I make the scene safe and determine that the person is not a threat to the community, but they are a danger to themselves, then I have to do is call emergency detention. So I bring them in, I do some paperwork, they ride in the ambulance with EMS, they go to the ER hospital, and I talk to the ER doctor and I just say, hey, here's the situation we're facing. She overdosed, or he overdosed, or she was cutting herself, or they were cutting themselves, and it's on me to determine what's the next step for this victim, basically, who is reaching out, or has a mental health episode going on, and I have to tell the doctor the next steps. When I have 8 months of training in mental health services, but this is a doctor that's been in the field for who knows how many years, whose background should be working and making sure this person's safe, where I'm just the person that gets them there. But it's that collaboration where maybe the training is a little outdated that you were talking about, that we need to step into the next generation and say, hey, maybe police officers shouldn't be the ones that's making the determination on where this person is or isn't going to go, because I'm not sure that police officers are the best ones to be doing that.
Yeah, excellent points, Craig. And I would just add, sort of the grand irony of them all, right, is that, it was policing agencies in partnership with their public health agencies back in 2015, when PARI was getting off the ground, that we were with our bullhorn saying that there's a disparate healthcare system that results in disparate policing in our communities in terms of criminalizing addiction and criminalizing serious mental illness. And it was police and public health partnering and raising awareness around those concerns that resulted in programmatic change, PARI, LEAD, other pre-arrest diversion for those that are largely on the lower end of the socioeconomic spectrum, and largely people of color who were being incarcerated because of their behavioral health condition or addiction. Now we began to see the pendulum swing and momentum get going. And one concern that I would be irresponsible not to talk about is this whole notion following the murder of Mr. Floyd to defund these programs and have the pendulum swing back toward a situation where we have disparate outcomes for people in these populations. I'm very concerned about that.
Yeah, Fred, you bring up a great point, and maybe I'd love to hear from the doctors, because one of the things that I found is that as we started to reach out to different experts, the right now public safety policing is willing, able, ready to change the way we've been, doing our jobs for history. I mean, again, we didn't know any better. Quite honestly, you go to the police academy, there was no mental health training. There was no substance use training. It was drug investigation, drug recognition training. Now we have mental health first aid training for officers, mandatory here in Massachusetts. We've got crisis intervention team training. So I think one of the things that, as public safety, we're kind of adopting that, mentality. Now we have a better understanding, from the public health side, from the doctors, I'd say, is just ask, what do you see this looking like, how this partnership should look like?
No, hey, go ahead, ladies first.
Thank you. I'll say that my concern in this conversation is the need to be intentional about words and languaging. I think that the word defund was probably the wrong word to jump out there with in terms of shaping and laying a foundation for this conversation, because ultimately, I don't think that's the right way to start. And I think oftentimes that's not truly what people mean. I think the conversation is really more centered around transforming partnerships and acknowledging where one part of the puzzle is more equipped to lead a response than another part of the puzzle. And to shape that further by understanding that where police may not be equipped to lead, at the very least, there needs to be funding for enhanced training. So it's not, to me, the ideal of defunding. Again, that's the wrong perspective to take, but it might be a shift of funding into other areas to provide the supports that police need to be effective in their jobs and to do their jobs in such a way that it doesn't cause harm. Because ultimately, everyone's working together to try to reduce and mitigate harm, or at least ought to be working together to try to reduce and mitigate harm. So my challenge to anyone listening is to, and it's not easy, I'm not trying to diminish how difficult this is sometimes, is to go beyond that first gut level reaction to when you hear a word like defund. It's not meant to, I don't think it's meant to be a personal attack on individual police officers, or in the long term, an attack on policing in general. It's more of a, we want to have a conversation that includes our perspectives and our needs and whether or not these resources can be more appropriately allocated. So that's my first challenge on that. I wouldn't want to, well, I'll say this, the challenge with that, especially in the oppositional environment in which we live and in which our politics, we are all steeped in it. It's like this soup that we all have to swim in. The alternative is now people are saying, well, if you call a police officer, someone robbed your house, they're not going to call you back for a week and a half. We know that's not true. But then, that's why I say challenge yourself to get beyond that first gut level reaction when you hear a word like defund.
Sorry.
Oh, no, you're fine. I want to just say mic drop after what Dr. Scott said, just a real quick add on to that when we talk about the programmatic piece. So, when I hear what Fred's talking about, it's like, hey, in the honor of individuals like George Floyd, wait a minute, let's do a hard look at how we're doing our programs, not just in policing, but across the public health agencies. As well. So one thing I want to really, exemplify a little bit is that if we're making decisions to have programs or to modify certain programs, how are we making them and what are we basing them on? Are we using enough data to equip our police officers to do better and to be in a good job? That speaks to the legislative piece at the local level primarily. All politics are local, right? And then sometimes it manifests at the state level. But it's really about helping our body politic at the local level understand that these decisions being made by only a small handful of people to do a certain program that may not be based on much information is egregious. So us as human beings, we are emotional, and that speaks to the word of defund. Humans tend to get into trouble when they misuse and misappropriate words. I think everyone wants to see things improve from both the public health and the public safety standpoint. Policing knows, they're like, we want better. public health usually is like, we want better, so I would also challenge anyone, that's in the body politic to engage with your local body, with your local legislators, and to ask, how are we improving policing? How are we improving public health? What indicators are we doing that with to make those decisions, rather than based off of a knee-jerk reaction or a gut-wrenching emotion, because that serves nobody any good at all. And it ruins our agencies and institutions even more when we make decisions that are based on falsified information or not good information. So that's my big challenge to that.
Or emotion.
Yes.
Usually policy that results from emotion is not good policy.
No.
Going off of how the use of particular language is so important, Dr. Scott, from the public health perspective, policing has many roles. Today, what distinguishes policing from law enforcement, in your opinion?
Well, I think about this from the community perspective, and how, at least from the perspective of an academic partner, we have to think about our communities, and what comes up is trust. So I have worked at medical centers, and we have to acknowledge the history of mistrust in medicine, just like we have to acknowledge the history of mistrust in policing. So back to languaging. When you hear police, oftentimes people respond again emotionally, and they're not operating from the space of the nuance of that there's also a piece of this that is entering into my world to try to ensure my safety, because their experience has been that oftentimes interactions with the police have escalated, whether it's been them personally or someone that they know. They feel they are left leaving those interactions feeling dismissed and diminished. So what's important is to help community understand the difference between policing that is, I'm out to get you, I'm coming down on your head because I have the power to do so to you, and the element of policing that really does represent the intention of public safety, which is to make sure you have the resources allocated in your community, and when they're needed for you personally, they're available for you and executed in a way that's respectful and does not diminish your humanity. People are left feeling, again, we live in an oppositional time in our history, and maybe that's to some extent always been the case, and we just haven't been willing to discuss it, but trying to get out of that space of me against them. How do we talk about each other? Do we talk about communities in terms of deficits? Well, these communities continue to exist. So the reality is there are some assets in these communities, even in the face of the things that may not be operating well. So I think it's important to just help people to understand that there is an element of policing that is positive. It's not always a negative thing, but it may be unfair at times, but then we have to show that. We have to show that from the public health perspective, that we're entering into these communities, not just to drop in and get data and information and elevate our own careers. And as police, we're not just dropping in to be able to say we've executed in the space of law and order. But my colleague Nate likes to talk about outcomes. So then it's like, what do the outcomes really show? I'm not going to steal his thunder, but that's my request for him to talk about outcomes.
Yeah, just really briefly, because I think we definitely want to get the policing perspective too. But when we do talk about the outcomes related to trust, right? This is where there's a lot of parallel and crossover with public health and public safety. Is that if you look, again, I'm a history buff. If you look at the history of public health, we have gone into communities and we have committed atrocities in which we've had to answer for to improve the profession. And also, I'm very cognizant of groups such as Systems for Action that want to improve the systems. So when we say, like, look, we want to right the wrongs and we want to move forward, then that's great. And what this group represents is just that. This group is saying, like, wait a minute, there's been some history in which it's like, that's not how it should go. And we've had success with doing, this cross collaboration between policing and public health, right? So when we talk about building trust, when we talk about addressing things such as substance use or substance abuse, we can get to those outcomes. But you can't do it in one entity. That's the magic slice. You got to do it together to have that marginal effect, right? Now, in the age of COVID, what's going to be interesting is that chronic health conditions will arise that will go into the behavioral health arena. people's brain function is going to be impacted. No one's really talking about that. How will they operate and function in society? What impact will they have to them from a public safety perspective? Because we didn't handle it from the right way from a public health perspective to include public safety to be more proactive and preventive. That's something we got to think about. So when we talk about trust and outcomes, it's paramount. You have to establish that equitable base, no question. So that's what I got to add to that.
Well said, Dr. Nate. So what I've learned is the first reaction to an event is an emotional one. And when we start talking defunding, like Dr. Scott said, is I don't think there's anybody that I know in the law enforcement community wouldn't say there's some changes that need to be made. Because if you look at what they're trying to change some of our responsibilities, I think a lot of officers agree. I've taken calls where a 10-year-old didn't want to get out of his bed because he didn't want to go to school. I've taken calls because somebody's boyfriend was cheating them on Facebook. I've taken calls where there was literally nothing I could do, but there was nobody else for them to call. So because there's nobody else to call, they call the police. And I'll go there and I'll do my best to help with the problems, but I can't be there for 10 minutes and solve something, a family issue that's been going on for the last 10 years. So I think when we start talking about collaboration, that's where I could call somebody and say, hey, there's a mom having difficulties with her child, doesn't want to go to school. Can we go over there and see if we can get to the root of this? Because a police officer going there, telling him get out of the bed, go to school may not have the long lasting effects that we want on this 10-year-old with his relationships to law enforcement. So I think that there are tons of things that can be taken out of the police responsibilities that will actually benefit the community.
Yeah, no question. And you know, that goes full circle, right, Craig, to Dr. Scott's point about trust, right? And you know, these partnerships are about building trusting relationships so that everybody's paddling, paddling the canoe in the same direction, right? Public health and public safety. But, you know, and clearly the trust issues with public safety and policing are front and center right now, 100%, and they should be. But to Dr. Scott's point, you know, there's trust challenges with our healthcare system as well, right? And so if we want to talk about disparities, we don't see doctors and lawyers at the methadone clinic in the morning, right? We see largely homeless people and people of color. Why is that? It's because our healthcare system is disparate. Our doctors and lawyers are getting a different treatment regimen for their substance use disorders than our homeless people are getting. And that lends to an environment and culture where there's mistrust and where addiction and behavioral health issues are then criminalized, where then police step in, and then we further exacerbate mistrust in the policing profession. So then we mistrust our healthcare workers, we mistrust our police, and it's a recipe for disaster. And these are the big macro level issues that we have been trying to tackle pre-murder of Mr. Floyd, that I fear will take a giant step backwards. Not intentionally. There's well-intended reform going on, but I really worry about taking a giant step backwards in terms of really getting to the root of the disparate treatment to those with substance use disorder and getting people the high-quality health care that they deserve, no matter where they stand on the socioeconomic spectrum.
Yeah, Fred, and because I want to just reiterate, you and I have talked about this quite often. We have this front row seat in law enforcement, and I've talked to various professional healthcare experts. I said, listen, we just, this kind of jumped on top of us where we're getting these calls. What I look at us as having that front row seat in the willingness to make that referral to the experts. As Fred said, I just get fearful, and that all of a sudden we're going to say, you know what, just go back in your, and do your enforcement. That's what I get fearful of, because I think as police officers and policing in general, we've made some great strides collectively across the country with, recognizing these disorders, that there needs to be some changes. And like Craig said, we're definitely not the right person for some of these calls. Let us do it together so we can get you, the expert, to connect that person to the proper resources. And that's what I've always said. I'm not advocating that, hey, law enforcement, police officers, we're going to become social workers and licensed clinicians. Although we are social workers, we just don't realize it because we deal with these issues every day. But it's now recognizing, hey, there are resources. Let's learn how to connect them to the professionals. And that builds that builds trust. It builds community trust. And it's really policing. I call it community policing 101.
Well, that and humility, right, Scott? Our law enforcement executives going to our public health professionals and saying, we need help. People are dying of overdose in our community. Help us manage this. And that humility itself builds trust, and that willingness to get out of your silo and just say, I don't know what the hell I'm doing here. I need your help.
Well, but to add to that, though, Fred, are our public health professionals saying like, hey, how can we intersect in your work to also get at that root cause? Because the policing profession is producing copious amounts of data to where all we have to do as public health professionals is to step in and look at police reports in such a nuanced way to say, hey, look, we got some recommendations. Help the job a lot easier. It'll help us improve some health outcomes. Not a major intervention. So that's the other thing. How often are our local public health departments making that humility jump too as well, to say that you guys know some stuff that we don't know that we need to understand. So it does cut both ways. You're absolutely right, Dr. Nate. And who would have ever thought that people would be accessing evidence-based treatment through the lobby of their police station, right? If that doesn't illustrate that the system is broken, nothing does. And that's where these partnerships have to come together so that we can move the dial. I like to tell the story. I don't like to tell the story, and that's bad. But there is a story of a young lady in our jurisdiction who overdosed twice. Twice we brought her to a Boston area emergency department. Twice they released her against medical advice, allegedly, AMA. And the third time she turned up tragically dead. And what resulted from that was, me and one of our captains driving to the emergency department and meeting with the leadership of the emergency department and having the what the heck conversation. We thought we were bringing this patient to safety when in fact, really what we may have been doing is exposing her to greater risk. Now, granted, that was back in 2015, but it's the willingness, the ability, and desire really to have those difficult conversations, because we weren't getting any political pressure to do this. We were doing this out of our value system. Something's wrong here. We need to fix it. And so having those humble, frank, and difficult conversations can move the dial.
Going off that thought, Dr. Nate, how can municipalities leverage private-public partnerships to advance society towards a more inclusive and equitable public safety and public health system?
I think that's a great question, especially when we frame it as municipalities, right? And when we say it that way, we're talking about, whether it be villages, towns, cities, and even, I like to say a county sometimes can be considered a municipality depending on, what kind of towns and cities are in it. But the main thing is that setup of the government structure is key, and being able to understand how a municipality can use and leverage the resources is going to be important. Municipalities, they have the ability to, solicit for services, through requests for proposals, to be able to say, hey, there's a problem here and we need to reach out. And being able to reach out and then to get that expertise that will come in and will work with, not come in and tell you what to do. They will work with your police department. They will work with your public health department and help to bridge this gap. And I'm not saying they're going to come in and have everybody do a round table and put sticky notes on the board. That's not what's happening. It's about using data-driven strategies. It's about getting real and having honest conversations and getting a lot of emotions out. Because usually when you're working in a municipality, you have, again, your body politic. You have a select group of people making decisions that are supposed to represent a vast amount of people. And if we can't get that understanding out on the table in that municipal setting, there's going to be a lot of like dysfunction. It's going to happen. And as Fred and I said earlier, a lot of decisions are going to be made out of emotion. So for municipal leaders to be able to take the lead and to bring in that expertise that cuts across all avenues. And when I say diversity, I'm talking about in terms of how people identify, in terms of how people speak to one another, in terms of how people perceive, in terms of how people believe. You cut across all those avenues, you're going to have a well-informed public safety and public health department. And specifically public safety, police departments will go for accreditation to indicate that they understand these cross-cutting edge issues. And when you can couple expertise from the private side with the police department that's accredited, you're going to get the biggest bang for your buck. And if you can do that with the local public health department that's on the verge of accreditation or that is getting accreditation, the same thing is going to happen too, because you're going to be, again, light years ahead of catering to a diverse population set. Again, I'm not talking about on the basis of just of race alone. I'm talking on the basis of how people think and engage with the community. So again, municipal leaders would be doing themselves a favor, and also the body politic, to be able to unearth a lot of things that have been festering for so long. And we're in the middle of that. So many things have been festering because we haven't been able to cut at it. And what you have now, you have some other municipalities that are doing Band-Aid type responses. You don't want that. That's a big no-no. So bringing in a public-private partnership to just do a Band-Aid response without thinking things through will lead to more catastrophes that are long-term. And it gets to the point to what Fred was talking about. You know, we recognize what happened to, you know, Mr. Floyd. We just don't want to just react. We want to say, wait a minute. We want to be proactive and you know, progressive about this in the public-private domain to bring in that expertise. So that's how municipalities can really look at this in terms of how that interaction is going to occur to get underneath that whole underbelly of all this festering and blow that up and dismantle all these things so you can create these new structures, because we are in a totally new paradigm now. COVID-19 has forever created another new paradigm in which we right now are not prepared for, and the municipalities that are doing that preparation right now will succeed in the next 10 to 20 years.
So I've been asked to follow up on that. Very comprehensive. The only two things that I would add to that is, once you get to the point of what Dr. Nate just described, it's the difficult work of resource allocation. No, it's one thing to come together and have these conversations and come up with the plans. But again, we have to be mindful of how people feel once the money starts moving in different directions. You know, how do we present this? What's the shared narrative that we construct around this? Because like Dr. Nate and others have said, this is a whole new space and time that we have to meet the challenges of this space and time. And I think we have to be realistic about the challenges that come with change. And it's not just leadership, it's about bold leadership. People will go and sit at the tables that they know they're supposed to sit at because that's what their title and designation indicate. But showing up to the conversation with the intention to change and transform the local environment and create models that work nationally, that can be tailored to other communities, but of course you're doing the work to tailor a model that can be transported and placed into other places. So if there's any concern from a public health perspective, is around the challenges of implementation science, and that it's really a long haul, and that we have to be thoughtful about ways to accelerate that timeline, because while we as people who are relatively comfortable in our careers and in our positions take our time to figure it out, there are people who are losing their lives in the face of this, or who are losing livelihood or quality of life in the face of this. So that's my plea for the sense of urgency, like the fierce urgency of right now, because what we've seen through COVID-19 and George Floyd's murder, it has totally flipped the underbelly of what was hidden in terms of the disparities in health and the disparities in policing. And those disparities didn't happen just because or just by happenstance. Those were systematic systems and decisions that led us to a society where there's so much difference between how certain people live their lives. So my follow-up on that is just to underscore the need to be realistic about those challenges and to find the right leadership to meet now. It's always nice to be able to be seen and talk and all of that kind of stuff, but people who really are doing the work are not the people you know about. So then how do you find those individuals and elevate their voices?
Yeah, I think, and I know we got to move on, Rachel. I told you this could be a 2.5-hour webinar. But the one thing, and I just want to say to Dr. Scott, is that urgency. You are 100% correct. It is that urgency. And really for us, and I know as a chief and before as the chief, as a sergeant that was engaged in my local coalition, it was that urgency. We had parents coming to us saying, hey, my son or daughter has overdosed 5-6 times. What are you doing about it? And we basically got to the point where we said, we need to think about this and find out, because they're coming to us. So I think that urgency is really what promoted or pushed us as, and I say us as in policing, into this behavioral health world, if you will, but always recognize, and I say this all the time, we got to stay within our wheelhouse. I know what my wheelhouse is, what my area of expertise, and I think that the capitalizing on our front row seat, and then with that sense of urgency, is really being able to push and promote, these collaborations. I just feel like, and I know Fred has mentioned this, I hate to see us take steps back, and just, if we can do it hand in hand, walking side by side, I just feel like we'll be so much more efficient and progressive.
And Scott, just very briefly, if I may drive home, Dr. Nate's mentioned a number of times the whole data piece, right? In our experience, our crime analyst put all these names up on a spreadsheet, and she said, I think we know who the high-risk population is that might fatally overdose. And I was shocked by that. I mean, we know who might fatally overdose? Yeah, they're right here. They've either re-entered from jail or they've previously overdosed. And the question became, what are we doing to prevent or anything proactively to get resources to this at-risk population? So that they don't fit, and the answer was nothing. So, having a good data set and that can inform policy decisions in this partnership with public health is what moves the dial. And I know you hit it out of the park in Plymouth with your data collection and analysis. I think that should be scaled up nationally, as far as I'm concerned.
Racial inequities exist in our criminal justice system, as well as our healthcare and behavioral health treatment systems across our country, as everyone was saying. I was wondering if, Dr. Scott, you could briefly explain what is racial equity for the audience today?
So, let's see. The most basic way that I like to think about this and explain it is that you can take any health outcome or any outcome in general. So it could be income, it could be education, it could be cardiovascular risk, it could be rates of incarceration in a community. And you have equity when race does not factor out as a predictor of that outcome. So me being Black or me being female or me being Christian, whatever, the different intersectionalities that we have, when we look at the data and we analyze it by any one of those categories, we should not see a difference across any of those groups. That's how we know we have equity. So conversely, we know we have inequity when we can look at things based on income, we can look at things based on zip code, we can look at things based on race, we can look at things based on sexual identity, and see that those things become predictive of a negative outcome. Or if you're on the upswing of those statistics, then they become predictor of a more positive outcome. That's how I like to explain it.
Thank you so much for sharing. Craig, can you discuss how you play a role as an officer with minority communities and or low-income marginalized populations?
Yes, thanks, Rachel. I just want to follow up a little bit on what Dr. Scott just said, but by the color of your skin, we can determine the likelihood of who you're going to marry, where you're going to go to school, what kind of healthcare you're going to receive. I mean, all of this by just the color of your skin, even to how long you're going to live on this earth. So race is extremely important. And I understand this as a police officer, especially as a Black police officer. So for me, it was getting to know the community. And I worked a specific area for 5.5 years. So for me, it was to get to know the people that were in my community. Because I wanted them to know me as well, so they can feel comfortable. And for me, it's always about making sure that the person I'm talking to feels comfortable. Know that I'm not here to judge them. I'm not here to belittle them. I don't care what your situation is. I'm here to treat you fairly and to treat you with respect. And I can't tell you how many times that went over very well. And they would call me Smitty on the streets, but I knew that they knew if Smitty was there, that they were going to be treated fairly and treated with respect. And that's why I was highly respected when I was a patrol officer.
So Rachel, I just kind of wanted to, as we're talking about, racial inequities, one of the things that I've learned is, I've learned to look at studies, all of the research that's out there. And one of the things that, it wasn't, aware to me was the disparities. We have disparities in criminal justice and law enforcement. In post Ferguson, Missouri, a lot of chiefs, and I know Fred, in Arlington did, is, we took the principles, the 6 pillars of 21st century policing, and really looked at our communities. And it was really a self-assessment of, hey, how are we addressing all populations? Are we fairly treating all of the marginalized populations? What can we do differently? And I know that the 6 pillars was a key innovative approach for law enforcement to change the way we policed. But as we look at the system in general, one of the things that I found with our model in Plymouth County was, if you overdose or are at risk of an overdose, it did not matter what race you were, what color you are, we're going to engage you. Everyone in our model has an opportunity to sit down with our team. And what I saw across our county, and our county's about 550,000 residents across the county, we had 80 or so what we call outreach officers, and they were diligently out there trying to track down, connect people with certified recovery coaches, social workers, and clinicians. And they had there was nothing about, is this a certain segment of the population? It was everyone across the board. If you were at risk, if someone called us and you're at risk, we're going to try to connect you. So I see this, and Craig talked about that positive engagement. What we found is when we did these post-overdose outreach knocks, initially we're like, geez, if one out of 4 successful, then we're hitting out of the park. We were as high as 65, 75% of the time. People are telling us they're not going to let you in. And what we found is by bringing resources to their front door and their living room seat, if they were homeless, to doing the due diligence to track them down, we found that engagement really went through the roof. So I just bring that up because I feel like the engagement of these, pre-arrest deflection models that we talk about, really it cuts across all, race, sex, orientation, regardless.
I was wondering if I could extend this question to all the panelists, but how can police and public health collaborate to address inequities in both policing and the healthcare system?
Yeah, sure. I'll start. And I know my colleague Dr. Scott has previously talked about I call it the idea of race. It's a socially constructed variable, and we have to talk about it. And as Craig said, it has become such an important factor. And I say, unfortunately, it has become such an important factor because when you get to understand who people are, and what people need to thrive. That's what matters the most. And as Scott just said, hey, we was going to everybody and anybody. We was coming to you. You're a human, right? Because they understood that we got you. Your skin tone shouldn't have to factor in if you're going to get taken care of or not. But as Craig said, it has come to that in our society. That's the unfortunate part. So for our systems to be able to dismantle the use of race in such a negative way is key. That may be unconscious, it may be conscious, but you have to talk about how we have designed a system that predicates itself on using race as a label to then make other associations that produces detriments to people to create other negative externalities throughout our societies, right? So that's where the leadership has to like sit and talk about it. And I always go back to the local body politic. That's my MO. I'm like, it goes back to the municipality. It goes back to who's making the primary decisions, whether it's a board or a select group or an elected body as a council. It goes back to them. And a key point I would like to say is that there are municipalities that have said racism is a public health crisis because we know racism generates a lot of negative health outcomes through the method of stress, because we know stress erodes all bodily functions. It's like the end all be all to disease. So if we can get to that point to name it and declare it and then go after it to dismantle it collaboratively, that's where we make the most progress. And as I said before, that's what this group represents, is we are collaborating and we are being honest about not just what we're seeing, about what we know through our lived experiences, and we know what works. That's what's key to me in really getting at this.
And I would add, to Rachel's question, just to, dumb it down for any cops in the audience, I guess. This notion of transparency gets thrown around, right? Why is transparency important, and why is it one of the 6 pillars that within one of the 6 pillars that Scott mentioned? Is because transparency breeds self-correcting behavior, right? So if we're truly transparent with our flaws in our data, and stakeholders are able to point out disparate treatment or other systemic problems, we then are motivated to fix those problems. And so that transparency, again, breeds self-correcting behavior. And lastly, I would add, I like to call it the soft bigotry of setting low expectations. Our healthcare system sets very low expectations for certain segments of the population and high expectations for outcomes for different segments of the population. And that soft bigotry of just saying, go to the clinic every morning and get and that'll be your life, really is, do we want people just to survive? Is survival the only goal? No, we want people to thrive in their lives, to be healthy. And that's setting higher goals for people with substance use disorder and serious mental illness.
You're 100% correct. Healthy cultures don't happen by accident. You have to work. You have to work for it. And what I always tell my officers is, we have to worry about relations. We're a relational society. It's building those relationships so that when you see the person that you've been to his house 3 or 4 times in line at the methadone clinic, like talking to him about it, seeing like, well, what's going on? What can I do to assist you? How can I help you? And that's where we have to take our law enforcement hat off and put on our social service hat, as Scott said earlier, it's understanding what the issue is and trying to address it and fix it. And again, working with public health would be great, but we have to, as law enforcement, as police officers, we have to take a greater need in our community to solve the root problems. So to me, that's extremely important what you just said, Fred.
Today we discussed outcomes and how to improve them based upon data, research, and science. Dr. Scott, I have a question for you. What is the evidence and data related to harm reduction?
Okay, so when we're talking about harm reduction, it's addressing a concern with the intention of finding a solution without causing harm. So how do you show up in a space that's, could be, hard to read at first, could have someone who's ill, could have someone who's mentally ill. There are a number of factors going on, but your primary goal is to enter that space and not elevate the opportunity for someone to leave that interaction harmed. So how do you enter a space and ensure that wherever that person gets transported to next, whether it's a circumstance where that person needs to be arrested and transported to a jail, or it's a circumstance where a person needs to be escorted to a hospital, that they don't leave that interaction any worse than how they were when you arrived on the scene. So those are the concerns that we have when we think about, when we look at data on a broader scale and we're asking the question, what happened next? And going back to the issue of disparities, can we predict the opportunity for harm reduction or harm increase based on a person's age, neighborhood, race, sexual orientation? How is a person going to fare after this interaction? And I think when we think about that too, we want to know that we're in a community where the people who serve us are going to treat us like they would want to be treated. We're creating the communities that we would want for ourselves, and that we would want the same thing for other people. And I think that goes back to this conversation we've thread through today about trust, humanity, and humility. But basically it's about, can I interact in this space and not leave it worse than it was when I got there?
Yeah, I think the goal should be to leave it better. I tell my guys.
Yeah, true.
I tell my guys consistently that it's not treating somebody like you want to be treated. It's treating somebody like you would want your family member to be treated. And that's it. Just, would you be okay with how you handle this call if that was your mom or your dad or your sister? So to me, it's treating people not like, you want to be treated. It's treating them like how you'd want your family to be treated. And that's the expectation that I set personally.
Yeah, I think when we're talking, about how you'd want to be treated, it's throwing all the options on the table. And I know when we talk about harm reduction for law enforcement, in Massachusetts, we were fortunate to have the city of Quincy, Massachusetts, was the first police department in the country actually to carry naloxone, and that was a big step. For law enforcement, and Fred, I know we can go back those challenges where, we had police officers that were resistant, reluctant to do that because of the misunderstanding or the lack of knowledge, awareness of harm reduction and the positive impact that naloxone could have on saving lives. And I bring that up only because we're talking about, if you want to offer everyone the opportunity to get to their spot. And it may not be long-term treatment for them right then there, but it's meeting them where they're at. And I think that kind of goes hand in hand, not only with, treating people how you'd want your mom or dad or your family members to be treated, but also, giving them opportunities that it may not lead to success today, but it plants the seed, talking about, naloxone, talking about medicine to treat opioid use disorder. I mean, I know Fred, as a police officer, we had no idea what, medically assisted treatment was until, this all came to the forefront. So, those are some of the conversations that are critical when you're engaging with at-risk populations and then providing them with the resources or at least the information to help support them.
Yeah, and getting police officers to understand that we don't get to assign a value to people's lives. Every life has value. The person in the grips of addiction, no differently than the millionaire in the rich side of town. And our role is to serve all people. And somebody with higher power gets to set value to people's lives. It's not the police.
I just want to say a little reminder to the audience that we would love for you to ask us questions using the Q&A function at the bottom of the screen. If you type them in now, we can try to answer them before. I was wondering, what is Operation to Save Lives currently working on?
So thank you, Rachel. Yeah, basically we've put together a team of just trying to share the lessons learned from the public safety side of the house, but doing it in concert with public health. And right now we're really trying to help others across the country who are navigating in this this arena, if you will, of pre-arrest diversion deflection, and taking a lot of those lessons learned that have come through a lot of the PARI departments and some of the work that we've done in Plymouth County outreach. And then, as we're moving forward, really sharing those lessons learned. But even we've got a couple of curriculums, and even those curriculums, they were co-produced by public health, public safety, because it just needs to happen simultaneously. And, I know that with Dr. Nate and your work at Lelywop, that advocacy is similarly, that approach is doing this, hand in hand, step, holding our hands as we go through this together. So, anyone, we really appreciate everyone taking the time. I know we're getting a little bit late here, but we got about 10 more minutes, but we do encourage anyone that has questions to submit them. And what we're going to do is we're going to do a survey afterwards. We'd love to get some feedback. We'd love to see if people are interested in doing this again, maybe participating as a panelist. So we're really open to everything here at O2SL and Lelywop, and continuing this information sharing, lessons learned, and true collaboration.
Thank you
A
so
couple
much.
of questions there.
I was just going to say, 2 questions just popped up. The first one is directed to Dr. Nate. You spoke about public and private partnerships to deal with communities impacted by drugs and crime. The question is, any studies you would recommend so we can get the data?
So the trick about that is usually private entities don't release the data because it's proprietary. However, one of the things that Dr. Scott even spoke of is that researchers usually go in, do their thing, put a study out, and they leave. And the study becomes outdated or even antiquated, so it doesn't even fit well anymore. You can go back to models of community policing in the late 80s, even into the mid 2000s, and it's outdated now. Everything is moving so fast. So really you would have to design and develop this in an empirical fashion, which is one of the reasons why we're working together between O2SL and Lelywop. Because you really have to capture the data almost in a real-time basis. Like I'm talking about on a daily basis. So I'll give you a good example of that is that working with, in partnership with the Plymouth County Outreach, what we saw was data coming in on a daily basis, understanding how the hotspots fluctuated based on the actions that were made and based on how the municipality even talked and discussed about the opioid epidemic. That influenced how we were making an impact. So although that wasn't a private, public partnership per se, that was probably the closest thing that we had at the time. And now, things have evolved into where, like I said, we have O2SL, we have Lelywop, because you have a researcher's hat, and also you have, industry expertise from both public health and, law enforcement that are getting in on that. So one of the things that we hope to do is actually work with municipalities through curriculum development and also through implementing some of the data protocol and techniques that we have, so that we can generate that research to assist other municipalities. But I will caution and say that one size does not fit all when you're talking about these two dynamics. They are highly nuanced. So if you take something from another town and try to implement it the same way, it will not work. And another example of that is based on the work with the Plymouth County Outreach. Even though it was based on the county, the work done in each town was highly individualized based on the data. So you really have to get on the ground. You have to have some, really good expertise to really get at that. But looking at research to try to reduplicate it takes a lot of work. And like I said, within like the next 2 to 3 years, it's pretty much outdated in terms of best practices standpoint.
Yeah, and just for Nate, let us say with our O2SL, data platform it is the data of the municipalities that we're willing to, help them, and connect them to the researchers. Some might have a choice or a selection of a research already, but that willingness to share is, and work with various partners we're willing to do as well.
The second question we have today is, how can you make inroads with officers who continue to insist that taking drugs is a personal choice? And I was wondering if I could direct this towards Craig and Fred.
Sure. Well, and it's a great question, right? It's about implementing change, and adaptive leadership is sometimes about disappointing people at a rate that they can absorb, right? So as you implement these programs, slow incremental progress is critically important. But one, and I'll be very brief, and I'll try to convey this sort of a notion succinctly. One lesson learned that we applied to the opioid epidemic was the lessons that we learned around domestic violence. Back in the 70s and 80s, we treated victims of domestic violence very differently than we treat them in the 90s and 2000s. And that is, we used to put all the weight of the abusive relationship on the victim, on the woman. Why aren't you leaving this batterer? This batterer's a bad man. Why are you still with him? And all the other sort of, you need to leave this bad person. And as we learned about the dynamics around domestic violence and the police flawed response to domestic violence, there were many valid reasons why women weren't leaving abusive relationships. The biggest being hope, right? They didn't walk down the aisle hoping to marry a batterer. And they had hoped that their batterer would get better, so they stayed in these relationships. When you apply that to people in the grips of addiction, there are many valid reasons why people aren't ready to get into evidence-based treatment. And as Scott mentioned earlier, the importance of meeting them where they're at, just like we did with victims of domestic violence, and building a survival plan. Now, back when I was first trainer on domestic violence survival planning, I thought, what? We're going to plan for her next assault? Yeah, that's exactly what we did, so that she could survive that next assault, so that she could eventually safely exit the relationship. No different with people in the grips of addiction. Build a survival plan, work with them so that when they experience their next overdose, they can survive it, so that ultimately we can get them into long-term recovery. When phrased like that, cops sort of go, I get it. Yes, we learned that with domestic violence. That was successful for us. And I'm sure Craig has probably better frontline feedback than I do.
Hey, Craig, can you go quick, and then let's get to Dr. Scott, because we've got to wrap up, but I definitely would like to hear from you both before we close up here.
Yes, I just wanted to say that, to answer Julia's question, is simply, it's more training, right? So I think one of the biggest things to come out of the unfortunate murder of George Floyd was the belief that officers share is that if you're talking, you're breathing, right? That's the way I was taught. That's the way you're taught in the police academies, is if you're talking, you're breathing. And I've had to pull up study after study within the last 3 months to show officers that's not true, right? We're told that, and that's not true. So they're like, he's talking, he's breathing. And no, that's not how it works. So I think it's training, and you're just going back and showing the studies, and training is obviously expensive, but going back and showing studies that, yeah, even though he's talking, he's losing lung capacity, right? So he's not able to get in the oxygen intake that he needs. So to me, it's training. It's just a bias that officers have, or not maybe a bias. It's just they've been told, hey, taking drugs is a choice, and it's just the way they think. So it's seeing the examples like Fred just said. No, here is the actual data or the facts, so that that way they can change their mind and not keep passing this false information on to the next officer. So I think it's just training, basically.
Dr. Scott, can you bring that home for us?
Yeah, very quickly. So in that training, what are some of the key components? Because you can tell your colleagues these things that are true. One is that on a biological level, the brain, for some people, there is a predisposition to drugs and stimulants. So once they've tried it, they're more likely to have a problem with addiction. That's a fact. The other thing that we have to develop more empathy around is the avenues that lead people to try the drug in the first place. It could be something as simple as pain management gone awry, which we have seen as a result of the opioid pandemic. Someone had a knee surgery. Should you vilify them because ultimately that knee surgery led to an addiction? That's a fact. The other thing is to have some empathy around trauma, especially trauma during childhood. Has someone been sexually abused? Has a person been raped? Were they raised in an environment wrought with neglect? Were they physically abused? A number of reasons push people, or at least channel people towards those unfortunate decisions. And then if you compound it with how their biological system actually responds to the drug, then that might be a double whammy for that person. We have to develop some understanding around those things.
I just wanted to say, I want to be respectful of everyone's time as we've reached the 75-minute mark, but I would love to say thank you so much to all the panelists today, and thank you to the audience. And I encourage the audience to look for future webinars hosted by Operation Save Lives and Lilywop. And I also would like to say we would appreciate your input on our webinar today, and we'll be sending out a survey to all of our attendees.
Great. Thanks a lot. Great job, Rachel. Thank you for everyone for coming, and thank you to our panelists. Really great job. Have a great day and a great weekend.
Thank you.